الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه. Tularemia, due to Francisella tularensis, it is a work-related infection, also zoonosis, by Professor Mahmoud Hani Sulaiman. Definition: Tularemia is a zoonotic disease caused by Francisella tularensis. Microbiology: Francisella organisms are aerobic, pleomorphic, gram-negative coccobacilli. 3 species potential human pathogens are Francisella tularensis, F. phylomeragia, and F. hispaniensis. Only F. tularensis subspecies and F. tularensis subspecies whole Arctica relatively common. Infections due to tularensis generally more severe than whole Arctica subspecies. Infection dose in humans is 10 to 50 organisms when injected intradermal or inhaled. Tularensis is facultative intracellular pathogen. Recovery from infection depends on development of host cell-mediated immunity. Epidemiology: Tularemia is widely distributed but is disease of northern hemisphere. In US, cases reported in 2016 occurred in these states: Arkansas, Colorado, Kansas, Missouri, Nebraska, Oklahoma, South Dakota, Wyoming. Tularemia increase in late spring and summer. Reservoir: agomorphs and rodents. Rabbits, to less extent rabbits, hares, especially masquerades, voles, beavers, and prairie dogs. Transmission vectors: ticks and biting flies in US and mosquitoes in Europe. Ticks, biting flies, mosquitoes. Other routes of transmission: aerosol droplets, contaminated mud or water, skin contact with infected carcass, and animal bites. We'll give a lesson at the end of zoonosis about animal bites. Epidemiology: occupations with increased risk of tularemia. It is a work-related disease, work-related infection. Lab worker, farmer, landscaper, vet, sheep worker, hunter or trapper, and cook or meat handler. Clinicians should warn lab personnel if tularemia is suspected. Again, clinicians should warn lab personnel if tularemia is suspected. Tularemia spread by aerosol is a potential bioterrorist weapon. It is a bioterrorist weapon. Incubation period about 5 days. This is a very important table. Please print and use it. Why? Because it contains organisms about which the lab should be notified if suspected. So, if you suspect this disease, tularemia, you must tell the lab, and you must tell persons who will take the specimens for diagnosis, and you must yourself take the preventive measures to prevent your infection with these diseases. For example, avian influenza, Bacillus anthracis, Brucella, Clostridium, coccidioidomycosis, Coxiella, Francisella, hemorrhagic fever viruses, Ebola, Marburg, Chaper, Crimean Congo, Hanta virus, Kaiser-Werfer's disease, Lassa fever, and so on. Measles, MERS, Middle East Respiratory Syndrome, Severe Acute Respiratory Syndrome, SARS, Nipah virus, smallpox, Yersinia. It is a wide range, long list. It is all these diseases are healthcare workers infectious diseases. So you must take at any healthcare facility, you must take consideration of these, of control and the prevention of these diseases among the workers inside the hospital and the healthcare facility. Of course, if we said even influenza and SARS and MERS, we remember the pandemic now, which is COVID-19. This is the geographic distribution of Francisella subspecies and main arthropod vectors. Whole Arctica, and the vector is ticks. Okay, in these places, North America and North Europe and Asia. Tularensis, and the vector is mosquitoes, we said in Europe here and in some parts of North America. And subspecies Tularensis all tabanids, the vector is tabanids, like here and here. This table, epidemiologic and clinical aspects of tularemia. It is a occupational disease, professionally or occupationally exposed in these cases. Reservoir, lagomorphs, rodents, other wild and domestic animals. Geographic distribution, entire northern hemisphere among hunters and their households, farmers, trappers, vet. Mode of transmission for this: direct contact with live or dead animals, animal bites, ingestion, inhalation of infected fomites. Most common tularemia forms: ulceroglandular, glandular, oculoglandular, oropharyngeal for ingestion, oropharyngeal and digestive typhoid for inhalation pneumonia. Ticks, entire northern hemisphere, persons walking in tick-infested areas, tick bites and tick crushing, ulceroglandular, glandular, oculoglandular and typhoid. Mosquitoes in Scandinavia, persons walking near lakes and streams, mosquito bites, ulceroglandular. Tabanids, Western USA, outdoor activities in rural areas, tabanid bites, ulceroglandular, glandular. Contaminated environmental, water, mud, dust, grass, entire northern hemisphere, water sports, landscapers, and the mode of transmission: swimming, bathing, canyoning in infected spring water, ingestion of contaminated water, inhalation of infected mud, brush cutting. For swimming, ulceroglandular, glandular, oculoglandular, oropharyngeal. For ingestion, typhoidal type. For inhalation, pneumonic type. Please print this table and use it. Clinical manifestations. Tularemia starts abruptly with fever, chills, headache, anorexia, and fatigue. Often average incubation periods 5 days. 6 illness patterns, we mentioned them. Pneumonic and typhoidal tularemia are expected to be primary forms resulting from botulism event, pneumonic and typhoid. This can be due to botulism. Secondary rashes are relatively common. The most common complication of tularemia are lymph node suppuration and persistent disability. These are figures showing primary lesions seen in ulcerotularemia. These are 5 graphs. Please look at it and look at their description. These another 3 photos for tularemia. This shows tularemic lesion on the dorsal skin of right hand. Tularemia is caused by Francisella. Symptoms vary depending on how the person was exposed to the disease. As shown here, they can include skin ulcers. This shows 8-year boy with 7 days of fever, unresponsive to ceftriaxone. Examined because of occipital and post-cervical lymphadenitis, cervical lymph node drained purulent material. A culture of node aspirate was positive for Francisella tularensis. This figure shows tularemic ulcer on the thumb. Irregular ulceration occurred at the site of entry. Another 4 photos for a 6-week-old patient with vesicular tularemia, initially diagnosed with herpes simplex infection. Herpes evaluation was negative. The B picture shows a 10-year with vesicular lesion on arms and legs thought to be varicella. The arrow here shows vesicle near primary Escher. Evaluation was negative for varicella and herpes. Culture results of Escher and vesicles confirmed tularemia. The D shows varicella lesion shown for comparison. Again, another photo. Tularemia is a relatively rare infection that can manifest with painful cervical adenitis. This boy had a stick bite on his scalp that developed an ulcer followed by a large post-auricular node. His tularemia titers were positive and he responded to treatment with gentamicin. Diagnosis. Diagnosis rests on clinical suspicion, and because of its potential larger, lab personnel should be notified. It is potential danger. Lab personnel should be notified whenever tularemia is suspected. If tularensis is a tire select agent and its possession and shipment are tightly restricted. Routine cultures and smears are often negative and diagnosis is frequently confirmed serologically. PCR not widely available but offer a rapid diagnosis. This shows X-ray of untreated tularemia pneumonia. This patient remained symptomatic more than 3 months. Diagnosis established serologically when poorly developed granulomas were found in transbronchial biopsy specimen. Other causes were excluded, and exposure history was finally obtained. Again, X-ray for chest, tularemia pneumonia. Postero-anterior chest radiograph showing pneumonia, pleural effusion in lower lobe of right lung. Pneumonia was unresponsive to ceftriaxone, azithromycin, and nafcillin. Patient had history of tick bite and high fever for 8 days, and his tularemia agglutinin titer was 1 to 2048. An outbreak of pneumonic tularemia prompted consideration of botulism. Therapy. Streptomycin and gentamicin are drugs of choice for all forms of severe tularemia except meningitis. See table. Selected adults and children with mild moderate disease may be treated with oral agents. Surgical intervention is typically limited to drainage of saturated nodes or empyema. Prevention. The best prevention is avoiding exposure to organisms. A vaccine for tularemia is currently unavailable. Patients with tularemia do not need special isolation because person-to-person spread does not occur. Standard precautions for handling contaminated secretions are adequate. Antibiotic prophylaxis after potential exposure of unknown risk as stick bite not recommended, but according to the risk. Either ciprofloxacin, hydroxycycline, either given orally twice daily for 14 days. Recommended for adults with suspected or proven high-risk exposure with tolerances. Observation without prophylactic antibiotic is appropriate for exposed children and adults with lower risk exposures. This table is important and use. It is about the drugs antibiotic therapy for tularemia, including children in every category, if it is a serious disease, mild to moderate disease, or meningitis. Summary: tularemia is rare zoonosis caused by gram-negative bacterium Francisella tularensis, including subspecies type A and whole Arctica. The disease restricted to northern hemisphere. A wide spectrum of animal species are susceptible. Humans become infected by direct contact or bite or infected environment. Tularemia is often systemic disease with potential spread of bacteria to whole reticuloendothelial system due to intracellular lifestyle of tolerances, which can multiply in phagocytic cells as macrophages. 6 main syndromes recognized. These are them. Although usually mild, tularemia may evolve to be chronic, disabling, and even fatal. The high mortality rate of pneumonic form of tularemia explains potential use of tolerances for biological warfare. Patients with tularemia should be treated with fluoroquinolone, doxycycline, or gentamicin. وفي النهاية أقول الحمد لله رب العالمين الذي بنعمته تتم الصالحات. Thank you for your good listening.